Okay, so here's my little prairie dog looking like he's holding on to his lower back. We're going to talk a little bit about back pain, both lumbar and cervical, and then we're going to finish up with CVAs, cerebrovascular accidents or strokes. So here is the normal versus the abnormal anatomy when we have a lumbar disc herniation. So here is the intervertebral disc, which is provides us with cushioning and impact resistance, and it has kind of a hard cartilaginous outer ring called the annulus, and then inside that nice soft nucleus pulposus. And so the annulus protects that nucleus pulposus, that's nice spongy layer there. And sometimes that hard cartilaginous annulus can crack open because of various injuries or traumas or repetitive strain. And then the nucleus pulposus oozes out, and it's called a herniated nucleus pulposus, or HNP. So that will be the cause of a lot of cervical or lumbar disc pain. And how we diagnose it is by the history of perhaps some sort of a trauma, our physical assessment, MRIs, CAT scans, that sort of thing. So that we can, and the myelogram that we talked about, where they inject a water-based dye into via lumbar puncture, and they do a scan, and they can see where there's some misalignment of the discs or herniation of that nucleus pulposus. So what they want to do now is kind of conservative treatment before they start doing surgeries. So the conservative treatment is rest, alternating ice and heat, ice to reduce swelling, heat to relieve muscle pains and spasms and that sort of thing. They will put you in what's called the Williams position, which may or may not come up on the NCLEX, but it's something to be able to identify that. And that's where basically you're in the bed, your head of the bed is up about 45 degrees or so, and then the knees are gatched, the knees are bent, so that you're kind of reclining, which relieves the strain on your lower back. If your legs are flat, and that kind of pulls on the lower back. They will do NSAIDs, they will do epidural steroid injections, physical therapy, and oftentimes this particular issue will resolve on its own as the muscles go out of spasm and they tighten up and they strengthen, and you have good body mechanics as you're moving around. But occasionally surgery is needed. So there are primarily minimally invasive procedures that we try to focus on. The benefits of those is less muscle injury, less blood loss, less post-op pain. Oftentimes it can even be done in a day surgery environment or an overnight within 24 hours or so. They can do endoscopic, arthroscopic, laparoscopic, or percutaneous discectomies, laminectomies, which is removing a portion of the spinal column itself versus doing anything with the spinal cord. Anything that can help to relieve the pressure on the spinal cord or the spinal nerves. And then oftentimes we may have to go into a discectomy where they actually remove the disc and then fuse it together with bone cement or your own bone graft, where they will take some samples, shavings of bone from your iliac crest and use that to fuse the spine, or they can use cadaver bone to stabilize those vertebrae. Postoperatively, we want to do a baseline neurological assessment. There might be a slight deterioration in that as there is swelling after any surgery, but then as the swelling goes down, they will see some improvement. They may not be 100% pain-free. A lot of patients go into surgery thinking, oh wow, this is great, I'm not going to have any back pain anymore. And not so much, because there will be the incisional pain, the swelling and pressure on nerves that may take a while to go down. The possible complications with lumbar disc surgeries are problems with voiding, problems with bowel activity, as maybe some of the lumbosacral nerves might be impacted. With cervical disc surgery, Depending on the approach that they use, they can use an anterior approach where they go in through the front of the neck, or they can do a posterior. So a lot will depend on where the problem is and what is the best access to that problem. But obviously, if you do an anterior approach, that's right near the airway, the esophagus. There's a lot of nerves and blood vessels. So looking for any kind of respiratory complications, bleeding, swelling that could impact the airway, looking for any numbness or tingling in the shoulders, the arms, the fingers, problems swallowing. And then always looking for any kind of CSF leak. Look for that halo sign on the dressing. Check for the presence of CSF. So let's talk about strokes, cerebrovascular accidents. Basically, what's going on with a stroke is we have an interruption, a blockage of oxygenated blood flow to parts of the brain. So just like the MI was a blockage in the coronary arteries causing damage or death to cardiac cells, a CVA, a stroke, causes ischemic damage to your brain cells. Now, there are two types of strokes. Your book refers to the first type as ischemic. You may hear other sources refer to it as thrombotic, in other words, a thrombus or clot. Embolic. Embolic is where the clot has traveled from elsewhere. So all of those are blocking oxygenated blood flow from going beyond it and causing death to our brain cells. Hemorrhagic stroke is the other type, where we actually have a rupture or traumatic damage or tear in the blood vessel. So now the blood is leaving the blood vessel and it's not getting past that tear. So there are two types of strokes: ischemic, thrombotic, embolic, which are all interchangeable terms, and hemorrhagic, which is bleeding, a rupture of the blood vessel. When you think of risk factors for ischemic, thrombotic, embolic strokes, think of all your Virchow's triad. Think of valve damage, heart valve damage, untreated atrial dysrhythmias, one of the major causes of ischemic, thrombotic, embolic strokes. For hemorrhagic strokes, it could be an arteriovenous malformation, an aneurysm that has ruptured, sustained high blood pressure that has not been treated. So always be looking at what risk factors your patients might have. The problem is when they present with a stroke, a CVA, we don't know at first what type it is. So until we know that, we are not going to be able to treat it. So we are going to do CAT scans and MRIs and cerebral angiograms in order to determine what type of stroke that patient might have. Is it a bleed? Is it a clot or obstruction? So we're going to talk about Mrs. G, a 59-year-old widow who works full-time in the insurance company. Her hobbies are golf, traveling, and sewing. She is a non-smoker and a social drinker. So some of the risk factors that she has are the sedentary lifestyle, other than the golfing, the love of travel, driving around, so sewing, sitting at a sewing machine for hours. So she has some risk factors that relate to Virchow's triad. She reports that there was a possible TIA 6 months ago. So what is a TIA? It's a transient ischemic attack. So transient meaning it comes and goes. Ischemic, lack of oxygenated blood. So it mimics the signs and symptoms of strokes. Patients can have blurred vision, they can have some facial droop from weakness, unsteady gait, numbness, vertigo, syncope, problems with their speech. So they're stroke-like symptoms, but they resolve when that transient blockage, that transient ischemia is resolved. So we want to teach our clients the acronym FAST, the signs and symptoms of impending stroke. And patients who have had a TIA in particular should learn these. FAST, F stands for facial droop, A stands for arm weakness, S stands for slurred speech, and T, time is important, get help fast. Because just like time was muscle when we talked about MIs, Time is brain cells when we talk about strokes. The sooner the patient can get to the emergency room, we can determine what type of stroke, correct the underlying problem, relieve a blockage, start giving treatment, the less damage in brain cells to the brain cells that we see. So today she's presenting at the ED with slurred speech, right upper and lower extremity flaccidity. The family reports the patient has a history of rheumatic heart disease and a heart murmur. So what type of stroke did she probably have? It's probably an ischemic stroke because, number one, she had a TIA 6 months ago. Patients with hemorrhagic strokes do not have transient ischemic attacks. Once the bleed starts, it's not going to stop until we do something about it. So she probably had, because of her rheumatic heart disease and heart murmur, a clot that formed in her heart that was pumped up to her brain. It caused that TIA, and now she has what is now called a full-blown stroke because that clot was big enough to completely block some of her cerebral circulation. You do need to know some of this terminology, assessment terminology. It's not just used for strokes, but this is where I'm kind of talking about it. You'll see it when you're doing any kind of assessment with patients who have neurological issues. Dysarthria, that would be your slurred speech. Think ARTH, meaning joint. So this is a physiological problem with difficulty speaking because of muscle paralysis. Then we have aphasia or dysphagia. Look at the S in that. It refers to speech. And you can have expressive or receptive. Expressive is when I call that kind of word retrieval. You're having trouble getting the words out. You can think of what you want to say, but you just can't get it out there. Receptive aphasia is where you might be able to articulate words correctly, but you're not processing what's coming to you. So that's receptive aphasia. Apraxia is the inability to put sounds and syllables together to form words. So that can be very similar to expressive and receptive aphasia as well. Hemianopsia is blindness in half of the visual field. So here's a picture of what someone with hemianopsia might look like. They're losing, for example, in the top picture, you're looking out at the scene, they have lost the right side of their vision on both eyes. So it's the inner vision on the left eye, the outer vision on the right eye. And then the bottom picture is the reverse of that, where they have lost the left side of their vision in both eyes. So imagine how disorienting this can be when the patient is having those kinds of issues. Agnosia, the inability to use an object correctly. So sometimes in a stroke patient, you may hand them their spoon to eat their cereal and they grab it and they try to write with it because they're confusing what the object is and how to use it. Dysphagia is difficulty swallowing or chewing. So look at G for GI, and that's the difference between dysphagia with a G and dysphagia with an S. Alexia, difficulty reading. Agraphia, difficulty writing. And then something called extinction or inattention, and you may hear it also referred to as neglect syndrome. And this is the patient is unaware of the existence of their paralyzed side. Now, it's important to know that it is not an intentional ignoring of their paralyzed side. They literally do not acknowledge, they don't know that it's there. So that's, I think, why they removed that term neglect syndrome, because it kind of has the connotation of the person deliberately neglecting their affected side. But in this case, they just don't see it. They're not aware. So if they're brushing their hair, they're only going to brush one side of their face, of their hair. They're only going to wash one side of their face or their body. So there has to be significant retraining by occupational and physical therapy to get them to acknowledge the presence of their affected side and to be able to use it to its maximum potential. And now there are left hemisphere and right hemisphere strokes. Now, many of your patients will show signs and symptoms of both because they've maybe had multiple clots that travel to both sides of their brain. But most of the time you have an isolation of the signs and symptoms. So there are specific signs and symptoms related to a left hemisphere stroke, so the left half of the brain, which affects the right side of your body. And so in that particular case, we have right-sided paralysis and weakness, anywhere up to, depending on how much and how extent the damage is. They have problems with speech, processing speech, articulating speech. They are very slow and cautious and fearful, and get depressed and angry and frustrated very, very easily with a left hemisphere, right side of the body stroke. If they have a right hemisphere stroke, so the right half of their brain, it impacts the left side of their body, and they have left-sided paralysis or weakness or anything in between. This patient is very distractible and impulsive, has poor judgment, usually has receptive aphasia, so they may be able to verbalize and articulate what they want and what they're trying to say, but it may take a little bit of time talking to them to realize that they're not processing what you're saying to them, which can make for some interesting conversations. They also tend to be very unaware of their deficits and kind of euphoric and in denial, most likely to suffer extinction or inattention, quote-unquote neglect syndrome. So these patients are going to be very difficult to manage because they're very unsafe. They are not aware that they don't have the ability to stand up using their right leg, so they can fall very easily. You can give them directions to, for instance, ring the call bell so that I can help you to the bathroom or get you onto the commode, and they will wake up and, because of their neglect syndrome, their inattention extinction, will forget that you told them to ring, and they will try to get up. So very much of a safety issue. So for acute ischemic strokes, thrombolytic therapy, with all of the issues that we talked about when it came to thrombolytics for coronary issues. Anticoagulants, antiplatelets, many of our patients will be on a heparin drip. Anti-epileptic drugs, because of the damage to their cerebral cells, might have seizures or be at risk for seizures. Your ongoing neuroassessment, the first 72 hours, are critical because that is when the stroke can extend, when the intracranial pressure can increase. So we always have to be looking at our baseline and looking for those signs and symptoms of increased intracranial pressure. For embolic ischemic thrombotic strokes, we can do angioplasties, endarterectomies, removal of the clot, and even bypass. For our hemorrhagic strokes, radiologic occlusion or a craniotomy to be able to evacuate the blood that has accumulated and to sew up any ruptures or tears in the blood vessels. So our post-hospital care. Mrs. G's family does not want her placed in short-term rehab, so she's going to go home. What will be your discharge teaching? Think about all the things that she might need when she goes home. She has right-sided weakness. She has speech problems. She may have some swallowing issues that will have to be worked with if that's a continuation after her initial treatments. Think of the home care referrals that she will need. Visiting nurse, if she's on Coumadin, then the PT-INR. Physical therapy, occupational therapy, speech therapy. All of these are going to be needed when Mrs. G goes home. Mrs. G was my mother. She had a rheumatic heart disease. She had a bad mitral valve. She was referred to a cardiologist to have a valve replacement or repair when those were first starting to be done in the Hartford area. The cardiac surgeon said, "Oh, you don't need that just yet. We can wait." So 6 months later, she had the TIA. Carotid studies were negative. They didn't really seem to think that there was any kind of a link with her mitral valve issue. I was not a nurse at the time, so I didn't know to look into that. And then 6 months later, she had the stroke. She was 59 years old, worked full-time, very active, and then basically for the rest of her life was debilitated from that stroke We did get her to the point where she could walk with a quad cane. She lived in assisted living for a while, and then she had another massive stroke, and then was in long-term care. But very resilient, very stubborn, and ended up passing away in her 80s from heart failure because of that poor mitral valve. So 2 major strokes did not kill her, but the heart failure did. So that was her story, and it was a real tragedy because at the time it was not handled the way it should have been. And that is the end of our neuro lectures, and I hope you enjoyed them.